Hello and welcome to another episode of ICU Doc Talk. Thanks for joining me today. If you're new to this show, this is a podcast where I'm a medical doctor. I am an intensive care, critical care physician, and I am also double boarded in anesthesiology. I have a broad range of topics that I talk about on this podcast. I usually always talk about medicine, usually critical care or surgery or anesthesia related. And then I always talk about books. A large part of this podcast is talking about book reviews, mostly nonfiction, about economics or politics or history or science. And then I also share things about fiction, sci-fi, and fantasy that I read. And that's kind of the podcast. So thanks for joining me. And today, at the end of the podcast, I'm going to share a little stuff about. I'm also an author, and I was on an author panel with some really notable, awesome authors a couple months ago that I wanted to share with you, and I'll put a link in the show that you can watch that with some authors that you may have heard of, and I'll get to that just at the end of the show. So we'll talk about that. First up, the first part of the show is I call it Hot Takes from the Void, where I just briefly, about 5-7 minutes, talk about things in the news today and my hot takes. Today is April 21st, so let's take a look at what's going on in the news. Oh, I forgot to say my medical topic for this episode is vascular surgery. Kind of different vascular complications, needs that can happen from like Type A dissections to AAA, abdominal aortic aneurysms, those surgeries and taking care of patients like that. That'll be the medical topic for today. But first, let's take a look at hot takes from the void. All right, let's just bring up a news app here. I don't read a lot of different news articles, what am I saying? I don't subscribe to a lot of, I don't watch cable news, and I don't read, routinely any particular newspaper. But, I'm always looking at headlines and stuff, and I always try to understand things from a more of a historical perspective. Anyway, I digress. Let's see. AP News says Pope Francis, first Latin American Pope who ministered with a charming, humble style, dies at 88. So, yeah, Pope Francis was, I know he was. I saw he was, hospitalized recently with pneumonia, in and out, and at his age, with that, I figured that he would pass away soon. The first thing that strikes me about Pope Francis, I'm not Catholic. I am Christian, and I do have a lot of respect for a lot of things the Catholic Church does. Obviously, it's mired in a lot of controversy throughout the ages, not just recently, but throughout the ages, and there's plenty to be critical of as well. With the Catholic Church. My wife taught at Catholic schools for quite a long time, taught a lot of second grade and lots of different grades, and so I was exposed to a lot of, Catholicism and lots of amazing local Catholic communities in several different cities across the United States, and have a lot of respect for local parishes, etc. Anyway, Pope Francis, the first thing I remember about him is, I believe he's from Argentina, and I remember he drank yerba mate, which is a beverage. That's a caffeinated herbal tea from Argentina and Paraguay that I drink every day. I've been drinking yerba mate. It's highly caffeinated. I've been drinking it for like 20 years, and I love it. It's like a very bitter, earthy tea. Anyway, someone passed him a yerba mate gourd from the crowd that he was walking along when he was deemed Pope. I don't know how to say that. And he took a sip of it and gave it back. And I thought that was incredible for him to take a sip of a tea from the crowd. Anyway, I thought that was really cool. There's plenty to be, as I said, there's plenty to be critical of Pope Francis and the Catholic Church. But the guy just passed away. He seemed like he seemed like he genuinely cared about things that Christ seemed to teach about and talk about. So I did admire that. And I understand J.D. Vance visited him, and then he died the day after. Not I'm saying that those things are related, but I would want to die if J.D. Vance visited me while I was sick, because I absolutely loathe that man. Anyway, what else is going on? Let's see, I'm reading here. This is from NPR. The White House is looking to replace Pete Hegseth as defense secretary. So that's new that I'm seeing that for the first time. Not surprised. The guy seems like a moron. I think I read earlier today he used the Signal app again to talk about war plans. He's an incompetent buffoon, and I'm not surprised they should try to replace him, as they should, and hopefully it'll make the White House look weaker and Trump look weaker and lose face, which I would love, because Trump is a fascist, evil man, and I would like anything for him to look weaker and to lose support. I absolutely loathe that man and everything he stands for. He's evil. You call a spade. He's an evil fascist. That's indisputable. Let's see what else is going on. Supreme Court wrestles with challenge to Obamacare preventative care panel. Okay. Supreme Court, so they want to overturn some preventative care. That's all par for the course with the neo-fascists that are in control of the Supreme Court, the John Birch Society, the Federalist Society, these fringe libertarian people that are now at the head of the government in all branches. They will do everything to dismantle any sort of social state. And of course, that's all par for the course. That's all they want to do, and they want to replace it with a private corporate state to extract money and oppress the American people. Not surprising. What else is going on? House Democrats land in El Salvador to push for return of Kilmar Abrego Garcia. So that's the guy that I don't know much about him, honestly, but I know it's tons of controversy going on with him being deported by Trump, whatever administration, and he didn't get due process, which of course violates his constitutional rights. And sorry, there was a hiccup there. And of course, another constitutional crisis has evolved from that. And now you have Democrats, senators and politicians that are trying to capitalize on it, as they should, to try to bring that guy home and to try to cast Trump as a villain. And at the same time, these Democratic politicians will try to gain national prominence. So they're also self-interested in doing that. But I'm glad they're doing that. I mean, as they should. What else? U.S. Vice President J.D. Vance to meet Modi in Delhi amid tariff tensions. So that's interesting with these tariffs that he would go there. He's probably trying to create some sort of sweetheart deal. That's the whole point of the tariffs. Well, there's no logic. Don't try to find logic in the tariffs, but one of the reasons that they could be instituted is Trump is trying to institute a hegemonic control over the global economy where all economic decisions run through him. And this looks like that's probably part of that. J.D. Vance trying to broker some sort of deal with the Trump administration at the center of it. Anyway, what else? Anything else to talk about? It's exhausting, I know. Oh, one more. The Last of Us ripped off the Band-Aid from The Verge. So that's talking about The Last of Us Season 2. And I haven't seen the second season yet. So no spoilies from me. I watched the first season and loved it. And I've played the video games. And I'm actually playing Last of Us 2 again right now. And it's incredible. If you haven't played those games, they're incredibly violent. So keep that in mind. And I'm pretty sure I know what this article is talking about. The Last of Us ripped off the Band-Aid. I'm pretty sure I know what happened in the show, even though I haven't seen it yet. I won't spoil anything. But if it did happen, ooh, that's gotta hurt. You know what I'm talking about, if you know what I'm talking about. That's it. That's Hot Takes in the Void. Okay, let's move on to our medical topic, vascular surgery. Let's do it. Okay, so vascular surgery what is vascular? It means blood vessels. So a vascular surgeon is a very specialized surgeon who does surgery on blood vessels, arteries, veins, and that's kind of it. I mean, but just think how many arteries and veins are in your body. You have your aorta, the major artery coming off your heart. You have your ascending aorta, the aortic arch, the descending aorta, the thoracic aorta, the abdominal aorta. Those turn your iliac arteries and your and down into your femorals and your popliteals. Right, your arteries are the highway of the blood supply to your body. And you have your carotid arteries, your subclavian, all of these things, right? If you have a disease of these arteries, they can compromise flow to your organs, like your viscera, your coronary arteries, right? Now, backing up, coronary arteries are handled by cardiothoracic surgeons, not vascular surgeons. But anyway, carotid arteries, right? So you need a very specialized surgeon who knows how to deal with the diseased arteries and to repair them. So they're amazing. They have incredible talent and skill, and they also they understand veins as well. So the difference, just real quick, the difference between arteries and veins. I've probably said this on the show before, but I really wish some basic anatomy was taught in elementary school in the United States, because the average adult does not understand the difference between a vein and an artery, and they're extremely different. They're very, very, very different things, right? Arteries are highly muscular. If you were to dissect it out of a body and set it on a table, it would be like a tube. It would have a tubular shape. It wouldn't lose its shape. Whereas a vein is very flimsy. It does have some muscle tone, but not a lot. If you were to take a vein out of a body and put it on the table, it would collapse. It would be like a flat noodle. They're very, very, very different. Veins carry blood to the heart. They carry deoxygenated blood toward the heart. Arteries carry oxygenated blood away from the heart and supply oxygenated blood to your organs and your tissues, right? Okay. So I cover vascular surgeries in the operating room. I also take care of vascular patients in the ICU. I also take care of cardiothoracic patients. So I'm pretty experienced with helping take care of patients with the vascular disease. And there's just there's a ton. It's a huge topic, right? We could talk for hours about vascular surgery. It's not my intent. I just want to touch a couple basic things. I want to talk about type A dissections. Okay, that's one of the main things I want to talk about. So a type A aortic dissection. So what is a type A dissection? So what is a dissection? So you've probably heard of a dissection. You've probably heard of someone in the news dying. How did they die? Oh, they had an aortic dissection. What does that mean? What dissected? What actually dissected? Well, as I said, arteries have a lot of muscular tissue within them, right? And why do they have that? Well, they are one of the main components of your vascular resistance, right? So they squeeze and they relax. They vasoconstrict and they vasorelax, right? Or they vasodilate, whatever. Because they have smooth muscle and they relax and they tighten up. Now, what happens in a dissection is that the inner lining. So there's a bunch of different layers. There's the endothelial layer, which is muscular, and then there's a couple layers in between, and there's the adventitia, the outside layer of that vessel. A dissection is when the inner layer tears off the outer layer, but it still stays within the inside of the vessel, right? It doesn't go anywhere. And what is the issue with that? Well, okay, so that's what a dissection is, right? The inner layer kind of tears away and it kind of flaps in the wind of the bloodstream. And so you have it flapping in the wind. What's the problem with that? Well, anytime you damage endovascular tissue within an artery, you create clot. You create a clotting cascade. You are exposing a bunch of tissue to platelets and ADAMTS13 and all these coagulating factors that then want to clot, which is, of course, how it should work, typically, right? If you cut an artery, it's by design, right? If you expose the inside of that artery, like say it gets lacerated from a blade, or someone gets stabbed, well, all those clotting factors then but they coalesce around it to clot it off so you don't bleed to death, right? But now this is having a counterproductive effect when you have a dissection. This is all inside of the body. Okay, so an aortic dissection is a big problem. Why? Because, as I said, the aorta is the biggest artery that comes directly off of your heart, and it supplies the blood supply to your whole body. So if you have a dissection within that, you can be showering clot all throughout every artery that comes off that highway, right? The innominate artery, which supplies the carotid, the subclavian, the left carotid, right? Those carotids go to your brain, right? Your brain is supplied by the carotid arteries and the vertebral arteries for your posterior circulation. But the carotids are the main. Vertebral are very important as well. They supply the basilar arteries, which supplies like your brainstem, of course. Anyway, so I'm painting the picture for you, right? It's a problem. Now, why does someone get a dissection? It's usually uncontrolled high blood pressure. That's a very, very common reason. Someone has blood pressure that they have not controlled they have not put it under control for years and years and years, and it's too much pressure, and it just snaps, right? And it just tears away the inside lining. Now, you can also have connective tissue disorders that can make you have a propensity for a dissection, like Louis Dietz syndrome or Ehlers-Danlos syndrome, and there's Marfan syndrome. Can also you can have dissections from those as well. I believe the greatest number is because of uncontrolled hypertension. A typical patient with dissection flap is someone who doesn't go to the doctor ever, right? They just don't go to the doctor, and they don't know they have high blood pressure. They avoid the doctor. They don't care about their high blood pressure, and this is what happens. I see it every day. I see it all the time. high blood pressure is an absolute silent killer. It's unfortunate, right? Because high blood pressure usually doesn't hurt. You don't feel it usually. Now that can change if you have an organ dysfunction. High blood pressure can kill your kidneys. You get hypertensive nephropathy, right? It can kill your brain. You can get a stroke. You can get a hemorrhagic stroke. You can get heart failure, right? You can get AFib. You can get malignant arrhythmias. You can go to heart failure from uncontrolled blood pressure. It's one of the most dangerous things you can do to your body is ignoring your high blood pressure. Don't do it, okay? Now, if you're one of those people that's like, oh, I'll get it under control with my diet, okay, give that a shot. But if you haven't gotten it under control, bite the bullet and start some meds. You got to do it. It'll kill you. Seriously, it'll kill you. It will shorten your life if you don't control your blood pressure, okay? There's my PSA for you. Okay, so let's talk about Type A dissection. So this is a Type A dissection. There's different categories. I'm not going to get into too much. We usually refer to the Stanford type now, Type A dissection. There used to be, it was called the DeBakey classification. There's different ways of classifying. I typically just break it up to Type A, Type B. Okay, there's Type A dissection. That is a dissection. This all depends on the location. Where is it? It's a dissection of the aortic arch. Okay. Contrast that with Type B. Type B dissections affect the descending aorta or farther down from the heart. Type A dissection, this was my take home, is a surgical emergency. Surgical emergency, okay? Meaning if someone is discovered to have a Type A dissection, they need to have their chest cracked open. Let me back it up. They need to go to surgery emergently with a heart surgeon. They need to then have their chest opened up, and that needs to be repaired immediately. It's gonna kill them if it doesn't happen. Why? Because you have a dissection. So that dissection starts right as the aorta takes off the heart, and that dissection flap can cross over your coronary arteries. Right? Those are the first arteries that come off the heart. What do the coronaries do? They feed the myocardium. Right? That's how you get a heart attack. So they can cause a heart attack. So you can kill your heart. That dissection flap can go up to the carotids, clot off the brain, so you can die of a stroke. They can affect the subclavian arteries, your arms and stuff. And then all of that is threatened, right? So that's an emergency. And then you can also tear into your pericardium, and you can bleed into your pericardium and get cardiac tamponade and die that way, okay? So it's a surgical emergency. Now, a Type B dissection is a different story. If someone just has a Type B dissection, now that can be medically managed, or maybe it needs to be intervened on with a vascular surgeon. You need to consult vascular surgery for a Type B dissection, and you need to get the recommendations. But I've seen dissection flaps that start Type A, they can start at the carotids, and they come all the way down into the iliac arteries. Okay, if you understand your anatomy, you know that's it. So that dissection flap is crossing potentially the carotids, the innominate artery, the subclavian, the left carotid, and then coming down, it can your celiac arteries, your SMA, your renal arteries. It can cover all those things. It can the artery of Adamkowitz. I'm going to get into that in a second. And you can threaten all of those organs, and they can all die. And then the patient's life is in danger. A Type B dissection can be managed medically, or it can be managed with a endovascular repair, like a stent that goes up. And then you got to look at the scan to see if your organs are still getting supplied. Sometimes they're getting supplied by a false lumen. You got to see where that contrast is flowing on a scan. Okay, but let's go back to a Type A dissection. Okay, so now I'll often sometimes get a Type A dissection in my ICU, in the cardiac surgical ICU, maybe before surgery. Okay, and maybe the OR is being prepped, and it'll happen in like an hour or two. So they come to my ICU. My goal, this is before repair. Okay, my goal is to keep their blood pressure and their heart rate low. You must do that. You do not want to propagate the dissection flap. And as you got to make sure they don't have tamponade as well, because they might have tamponade. And if they do, because that flap is it's going to the pericardium, right, as I described, and so you have to rule out their tamponade. If they have tamponade, you need to do a pericardiocentesis, but it needs to be controlled, because you can take off too much blood, and then they keep bleeding out of that. And they can actually bleed through a pericardial drain. They can arterial bleed through a pericardial drain. That can happen because there's a connection between the aorta and the pericardium, and then your drain. So it needs to be a controlled release of blood coming out of the pericardium, that hemopericardium. That's a lesser point, but an important point as well. Okay, so my goal with this patient is you gotta keep their blood pressure low and their heart rate low. Okay, how do you do that? Well, you got to do it with IV medication, IV drips, titratable IV drips. Now, calcium channel blockers are fine. Clofidipine, nicardipine. You can use nitroglycerin. That's fine too. But usually a calcium channel blocker. Clofidipine is a great drug because it's easily titratable. Off on, quick off. Right, works really well. So that's how you lower your SVR with that. But if you still have a high heart rate, you need to get your high. It's not good enough. So you could have a normal blood pressure or a low blood pressure, but a high heart rate. That's a problem because your heart rate is creating shearing forces as well. If you're tacking away, sinus tack or whatever, 120s, 130s against a dissection flap, you're causing shearing forces directed at that dissection flap, and you can propagate that flap further. You do not want to propagate dissection flaps up the carotids or down the coronaries, right? The main coronary arteries causing dissections down, they're going to die. So you gotta put them on a beta blocker as well. And a drip. Esmolol is great. Now you can do labetalol, right? Labetalol is non-selective. But my first choice would probably be clofidipine and esmolol drip. These drugs come off very quickly, fast on, fast off, very, very fast. And you want that because they're going to go down to surgery. And they're going to go to cardiopulmonary bypass surgery. So you don't want something lingering around a long time before they go and be induced with general anesthesia and have wildly labile blood pressure. So I think an esmolol drip and a clofidipine drip are great for that use. Now, people with type A dissections, they often have type B dissections as well. As I said, that flap can extend all the way down. So not only do you need a cardiac surgeon in place knowing about this patient and prepping an OR, because they said it's emergency, right? It's not urgent, it's emergent. It's an emergent surgery to correct a type A dissection. But you also need to consult your vascular surgeons to come and weigh in on what to do with the type B dissection. Often they wait, right? Often they can be like, well, we'll manage this medically, meaning control the blood pressure and the heart rate, and we'll address this after the type A dissection is addressed. So I wanted to share a story. I don't think I've shared this story on the show. If I have, forgive me, but it's a good one. So with lots of good teaching points. So I had a patient who had a type A dissection. This was a patient who didn't go to the doctor, was not aware of his medical conditions, things like that. So he had a dissection, and he went down to surgery, and he had it repaired, and it was a long surgery. It was very complicated. He didn't have any deficits, right? And this dissection flap went up through the carotids, etc. It was bad. It was a bad dissection. Went all the way down through the bilateral iliac arteries. Surgery went okay. It was his type A, his ascending aorta was repaired. And so he came to my ICU, and I took care of him after that. Now, this patient, he took a bit to wake up, so which I was concerned about, because you have to rule out, hey, has he had a stroke? He has many reasons to have a stroke, a patient like this, from the dissection, and also just being on cardiopulmonary bypass surgery can put you at risk for watershed strokes, also hemorrhagic strokes, because you get an enormous slug of heparin, and you can have spontaneous bleeding from that. So it's right. Heart surgery is dangerous. Just baseline, it's dangerous. Anyway, he was okay. He woke up. I extubated him, like later that day after his surgery, and he was kind of doing okay. Now he still had his type B dissection, right? So he still had this dissection flap all the way down through his iliacs. Okay, meaning that flap is running all the way down from the repair down through his iliac arteries, covering and with a lot of organs at risk. Everything was working beforehand, and he was getting nice and contrast, through like a false lumen for his kidneys and stuff. And his kidneys were working okay. Now, I don't know, post-op day 1, a PT comes up to me, and she was like, hey, he can't move his legs. I was like, what? She's like, did you know that? And I was like, no, that's new. So I went in, right? If I hear something like that, I immediately go and see the patient myself, right? Immediately, you got to do a physical exam yourself, confirm, got to appreciate what's going on. So I went in, and sure enough, he could not move his legs. Only his legs. Everything else moved just fine. Okay, his arms could move. All that. And he was neuro intact. He could talk, he was joking, stuff like that. But he couldn't move his legs. and he had no hip flexion either, so he couldn't raise his legs and he couldn't move his hips. He couldn't flex his hips and his thighs. So that was all very concerning. So obviously I was worried about the dissection flap and something being clawed off, namely his spinal arteries, right? This is a spinal ischemia, right? And it's lumbar. It's more lumbar spine ischemia. What is the artery that immediately came to mind is the artery of Adamkowitz. What is that? So the artery of Adamkowitz, that's spelled Admkiewicz, Adamkowitz. It's also known as the great anterior radiculomedullary artery. And it provides blood to the anterior 2/3 of the spinal cord, right? Including the motor pathways. It's typically T8 through L1, but there's variations. And if it's damaged, you get spinal cord ischemia, and it causes anterior spinal artery syndrome, which leads to, like I said, paralysis, loss of motor function, and loss of pain and temperature sensation, which he had. So I was like, that is what definitely is what is going on. So we, urgently consulted our neurology colleagues to come and take a look at the patient. But I was like, this is definitely, this is spinal ischemia, and the immediate thing to do is to put in a spinal drain. Okay, so why do we put in a spinal drain? What even is that? What is a spinal drain? So a spinal drain it's basically a spinal. If you're familiar with a spinal anesthesia, it's a very similar technique, and it's the same space that you're trying to reach. Now, if you recall, I've made an episode, a few months ago about epidurals and spinals. You can go back and listen to that if you're not familiar with epidural anatomy and spinal anatomy and what those things are. So if you recall, an epidural is where you place a catheter in the epidural space above the dura, right? That membrane, the meninge. So you place a catheter above that, you give some numbing medication to bathe the outside of it, and you can get analgesia for many different reasons. A spinal is where you puncture the dura, you try to get into the CSF and deliver some medications into the CSF, the cerebral spinal fluid, where the spinal column, the spinal cord actually sits. So it's a more direct access to that. A spinal drain is I'm trying to get access to that same spot. So you try to go through the L3, L4 spinal vertebral space, well below the level of the spinal cord. Otherwise, you might puncture the spinal cord. And you put a drain in. You leave a drain behind, and you drain off CSF, right? So I'm not delivering medication, but I'm draining off cerebral spinal fluid. Why would that help in this setting? The reason is it's all about the pressure gradient of the spinal cord. So what's going on? So an organ, any organ or any tissue bed, its perfusion is dictated by kind of two things: a driving pressure and a distal pressure. Okay, driving pressure, the pressure that's being driven into it, and the distal pressure, the pressure that is opposing that driving pressure. And your driving pressure must be greater than your distal pressure, or else you will not perfuse that organ. Let's take the heart as an example. The driving pressure is the coronary artery pressure, right? That's the driving pressure that perfuses the heart. What's the distal pressure? The myocardial tension, wall tension. That tension, if it's too tense, you are diminishing the gradient of the driving pressure to the distal pressure, that ratio. So your driving pressure has to be great. This applies to any organ. Think of the brain, right? If your intracranial pressures are too high then over your driving pressure, which is your MAP, your mean arterial pressure, then you will stop perfusing the brain. It's the same thing. Here's the same thing with the spinal cord. So what is the driving pressure? It's the MAP, the mean arterial pressure. What's the distal pressure? The CSF, the pressure of the CSF around it. So, and it's not that this patient, so a spinal drain is the answer, is what you do. So if you are worried about spinal ischemia, you put in a spinal drain. And it's not because the CSF, the ICP pressures, intracranial pressures are too high necessarily. It's just that your driving pressures are too low because they're being blocked. So what I suspect was going on with this guy is that his artery of Adamkowitz was clotted off. So he didn't have any good perfusion to perfuse that part of the spinal cord. And so he needed a spinal drain to siphon off cerebral spinal fluid to lower that distal pressure so that any other driving pressure, that weak driving pressure, could overcome and start to perfuse the spinal cord. Okay? That's the reason behind this. So with neurology, I was like, you know what? we really should just put her in a spinal drain. I'm like 99% sure that's what's going on. But they were like, we really should get imaging first. And I was like, that's fair. I'm like, that's fair. Cause they were like, this could be a number of things. And I'm like, yeah, it could be, but it's probably the dissection flap that's getting in the way of the artery of Adamkowitz. But I relented, cause it was certainly reasonable to go try to get an MRI, which he needed. Of course, this patient went down for emergent MRI, moved too much, and there was too much artifact on it. And we didn't get any answers, unfortunately. I was like, I'm putting in a spinal drain right now. So I put in a spinal drain, and which was a challenge, right? So I had this patient sitting up on the side of the bed, make sure he wasn't falling over, gave him a little sedation, had 2 nurses helping so he doesn't fall over while I put in a spinal drain. A spinal drain is huge. It's very large. So I put this down, L3, L4, trying to find that space. And I finally got it. Took me a hot minute. It's not easy. And I got through the intralaminar space and punctured the dura, and I took out my stylet out of my spinal drain and got just a tsunami of CSF just splashing out, which was like a lot came out. Hard to know how much because it just splashed. I knew it would. This is what happens, because basically this guy's entire CSF column of pressure is sitting above that, and I released that pressure. So I threaded a drain, a catheter through that needle, taped it to the back, and then you're siphoning off, you can either drain CSF by quantity, you can do like, let's take off 10 cc's an hour, or you can do, in interval draining, like every hour the nurse comes and just takes off 10 cc's, and you measure your ICPs through that. You can transduce your ICPs. You can do it by ICPs. There's many ways you can do it. And I followed my neurology colleagues' recommendations for that. Anyway, so we put that in. Next day I came back to work and his legs could move. So so that therapy was definitely the right thing to do. And he got over it. The spinal drain came out and he got through his spinal cord ischemia. And then he needed obviously some sort of repair of his type B dissection. That would be worked out with vascular surgery. Whew, I had a lot more to talk about with vascular surgery, but I'm out of time. So I guess this was mostly just a type A dissection episode. Maybe I'll do more vascular. Like I want to talk about carotid endarterectomies. We could talk about AV malformation. What's the word? Resections. We should talk about aneurysms, cerebral aneurysms, and subarachnoid hemorrhage and the management of those things. I should do another episode. Let's do another episode about those kind of things. Very important. So I'll wrap it up. I think I got some emails. Let's check it out. All right. This is an email from somebody who did not give their name, which is fine. They say, I've been listening to your podcast since its inception. That's awesome. Thanks for listening. I think I've been doing this for 2-3 years. Why not spend some time talking about your writing process? How do you make the time to write? What's your writing discipline? Do you work with an editor or publisher? Where do your ideas come from? How do you self-publish work? And is it expensive? Why do you write? Can you share your observations or personal experiences about having a medical marriage? Okay, so let me address some of this stuff. So I actually I did an entire podcast. I did a podcast about how to write a book a while ago. It's episode 35. That was published April 10th of 2023. I discussed how to write a book and how to pursue your creative aspirations. So anybody can go check out that episode. But to briefly answer this person's questions, how do you make time to write? Anything that you're compelled to do. Okay, let me back it up. So I publish books, fiction. My 8th novel is coming out May 15th. A lot of times people ask me, how do you have time to write? One time I had a colleague come up to me and he said, and he said it perfectly. He's like, I bet people ask you, how do you have time to write? He's like, but I know the answer to that. It's how do you not write? You're compelled to write. And I was like, that's exactly it. When you have a creative aspiration, nothing can stop you from doing it. And that's with me in writing. I love writing. It's a passion. I'm compelled to do it. I don't need to find the time because I enjoy it so much that at any free moments I have throughout my busy life, being a parent and having a busy job, I find time to write. And I can write about a book a year. So if you love something enough, nothing can stop you from finding the time to do it. Seriously. I know maybe it sounds a little melodramatic. But I'm not, so my writing discipline, it's not, I try to have a goal. I try to write maybe 500 words a day, but I'll go a couple weeks without writing because my life is just too busy and too erratic. Not erratic. My schedule is too volatile and unpredictable often. But you write it here, there. Seriously, you write 200 words, 300, 500 words a day. You do that consistently, you will write a book. It's just about consistently doing things. And you know that. Everybody knows that. Where do my ideas come from? I read lots of sci-fi and fantasy. I read lots of nonfiction. They come from everywhere. I mean, I get ideas running in the park. I get ideas just in the shower. Ideas come from everywhere. And then self-publishing. I did have a publisher for my first couple books, but then I switched to self-publishing, which I love. I love doing publishing on my own and hiring skilled people to edit my books and do artwork for my books and voice actors. It's all part of the hobby, and I absolutely love it. So I write because it is a truly exciting thing. It's one of the most exciting things in my life is writing, is coming up with fiction and creating my own worlds and putting together the puzzle pieces of a novel. Just to this question, can you share your observations or personal experiences about having a medical marriage? I do not have a medical marriage. My wife is as I think I mentioned earlier in this episode, is an educator. She's been a long time educator, very skilled, master's in education. She's taught second grade, junior high, special ed, lots of stuff. So I can't speak to that about having my experiences having a medical marriage. But I can say that I'm glad I don't have a medical marriage. I love having somebody that's in a different world than I am, and to share that world with her, I think is really awesome. So yeah, thanks for writing that email. Okay, another email from Matt, last name withheld. My name is Matt. I had a few questions regarding the different pathways to critical care, as well as the future of anesthesiology as a specialty. As a current EMT and an avid listener of your podcast, I've truly fallen in love with the acute physiology and of life discussion critical care has to offer. I was wondering if you could provide your opinion in the various strengths and weaknesses associated with each pathway to critical care, like internal medicine, anesthesia, surgery, EM. Knowing what you know, would you still go the anesthesia route? So to first answer that question, yes, I would 100% do anesthesia. But I'll follow with anesthesia critical care, but I'll follow that up with anybody can be a strong intensivist regardless of your pathway, whether that's being a surgeon or going through emergency medicine or in internal medicine. I think the strength of being an anesthesiologist going into critical care is anesthesiologists are kind of half critical care physicians to begin with, meaning we do a pharmacology and dynamic physiology in the moment already in the operating room, with many various dangerous, patient situations. And, we already know how to run codes and already know how to run a room. We also you already have the skills to do things with your hands right away, technical skills and life-saving skills, where you might not have those coming from an internal medicine background, where you might have those more surgery and emergency medicine. Internal medicine, their strength is that they to run a medical ICU, you have to have more of an internal medicine background. And their strength is being able to very accurately, investigate disease processes and the underlying disease issues that somebody's having that has led to their critical illness. That's a huge strength as well. But knowing what I know, I would definitely do anesthesia as again, going into critical care. I think we make great critical care doctors. Matt goes on saying, additionally, can you speak on the future of anesthesiology as a medical specialty? I think the future is bright. Anesthesiologists are always in demand. Always. You'll never meet an anesthesiologist out of work. We are vitally needed for hospitals to make revenue. And I know it's sad to couch in a medical discussion with revenue, but most hospitals in this country are a business, and you needed anesthesia staff how do you generate revenue? By doing procedures and by doing surgeries. That's how hospitals generate most of their revenue. And you needed anesthesiology staff to facilitate those surgeries. With the rise of CRNAs, or nurse anesthetists, and AAs, anesthesia assistants in the operating room, do you think job security and a reimbursement for physician anesthesiologists will be at risk in the near future? I don't. So there is a rise in nurse anesthetists, but nurse anesthetists have been around for like 100 years. They really have. they're not new. Nurse anesthetists are not a new phenomenon. There have always been nurse anesthetists, almost since the inception of the specialty of anesthesiology. I do not see. So yeah, there could be a threat of nurse anesthetists having independent practices. Now, I will say, I think the better care is to have an anesthesiologist at any time there's operating room and anesthetizing conditions. I do not think independently run nurse anesthetists. I do think that's inferior to having an anesthesiologist. So if you have say a surgery center and there's only nurse anesthetists there, yes, unequivocally, I think that is an inferior care to an anesthesiologist. Now, are they running safe anesthetics on ASA 1 and 2 patients? Yeah, of course. Nurse anesthetists are highly trained and competent anesthesia clinicians, and they can do that. However, if something goes wrong, you want an expert in resuscitative medicine, which is what an anesthesiologist is. And I say that unapologetically. I will just say, and this is someone who loves the nurse anesthetists, works with them, and understands their skill and how vital they are. If me or a loved one was having surgery at a center and it was just nurse anesthetists there, I would not have surgery there. I just wouldn't. It's safer to have a trained anesthesiologist that's also working. Now, I'm talking about an anesthesiologist that's covering rooms with nurse anesthetists. But again, yes, nurse anesthetists can independently practice in many parts of the United States, and they do it safely. They do. I know that, and I recognize that. It would be better if there was always an on-site anesthesiologist, of course, and you can't make an argument otherwise. I've seen nurse anesthetists try to make a bad faith argument where they point to some research where they say the outcomes are the same. I've looked at that research. It is sponsored by nurse anesthetist program groups. It was funded by them, and those suffer from a selection bias. They only look at ASA 1 and AS 2 patients and their outcomes, right? You don't want just a nurse anesthetist if you have a patient on ECMO in the OR, okay? That's just the bottom line. And I say that unapologetically. I don't see a risk in job security to anesthesiologists. No, definitely not. That's not a thing. Matt just finishes off his email. I was very burnt out during my medical school application process, but I truly believe your podcast reignited my love for medicine. Thank you for being a source of inspiration for all the current and future generations of physicians. Matt, thank you. Thanks for writing it. I'm glad to play that role in your life. Okay, I'm gonna move on. To books. Now, I have a book series to recommend that I want to talk about. It's the Lady Astronaut series by Mary Robinette Kowal. Now, she's an awesome writer that I've followed for quite a while, and she does a podcast with Brandon Sanderson. And I recently got into her books, and I wanted to bring her up because I was on an author panel with her recently, and I'll share the link in this podcast so you can go watch it. It's on YouTube, and I was with 2 other amazing authors. So it was me. My pen name is Wick Welker, Welker, and then Mary Robinette Kowal, and then it was Malka Older. She wrote the Infomocracy series, which is really good. And then another author named Sue Burke. She wrote the Semiosis book series about the sci-fi series that I've also read. I've read books from all these amazing authors. And I was on a panel where we discussed what was our topic? Is science catching up to what was once sci-fi? And this was it was called TBRCon 2025. It's like a sci-fi symposium where we do a bunch of conferences. And it was with these amazing authors. And I was honored to be invited to be with these incredible authors. They're all phenomenal. And Mary Robinette Kowal, as I said, I followed her for a long time. This was sponsored by Fanfi Addict, like a blogging sci-fi site. Anyway, Mary Robinette Kowal, I followed her for a long time, and I've read some of her books, and I've listened to. She has this awesome podcast with Brandon Sanderson, the fantasy writer, called Writing Excuses, which you should definitely check out. And we had this great discussion where we just talked about what does sci-fi look like today? What does our future look like today compared to sci-fi? And it was awesome. It was fantastic. As I said, I'll put the link with this podcast and you can watch it on YouTube. And I just want to talk about her Lady Astronaut books. The first book is called, what was it called? I'm just looking it up. It was called The Calculating Stars. And it's a historical fiction series where but alternative history where in like the 1950s, a comet hits the DC area. And this is not big spoilers because this happens in the first book. It wipes out DC and it threatens the Earth with global changes that are going to like be a catastrophe over the next 20 to 30 years. And in the 1950s, this changes the course of humanity's goals, and which is to colonize space, to escape Earth that's going to be doomed in like a few decades. So that's the beginning of the book. And there's 4 books. The 4th one just came out. The 4th one's called The Martian Contingency, and I'm reading that right now. But this book features like a polymath computing genius named Elma York, and how she aspires to become an astronaut in the new astronaut program. And she faces, sexism. And then she's white and Jewish. And she, the first person POV kind of explores her challenges, and then also the challenges of her black colleagues during this era and their challenges in trying to be astronauts as well. And it's really great. It's very, Mary Robinette Kowal, I think, very impressive. Her research in orbital mechanics and space travel, really, really impressive. I don't think she has a formal background in those things, but you would think she does because she's done so much research and really puts the science in these books. They're really engrossing. As I said, I'm finishing the 4th, and I listen to the audiobooks, and Mary Robinette Kowal does the voice acting, and she's incredible. She's amazing. Really, really impressive. So I do want to recommend those books. They're called The Lady Astronaut Universe, and the first book is called The Calculating Stars. Highly, highly recommend. Check out those books, and then check out the YouTube video I did with her and those other 2 really great writers. All right, and then lastly, I have a book coming out May 15th. It's called Dark Prophet. My pen name is Wick Welker, Welker. It is the 3rd book in a series called Dark Law. The first book is called Dark Theory, and it's about a robot who wakes up in a junkyard in the distant future and has no memory and plans to rob some dark matter in a castle heist with a thief. There are only 5 stars in the night sky, and something is deeply wrong with the cosmos and the universe, and that starts an enormous sci-fi fantasy adventure that I am writing. The next book comes out called Dark Prophet, May 15th. It's going to be in hardback, paperback. My voice actor is recording it now. She's done an amazing job. Her name is Elizabeth Phillips. So if you want to get in that series, check it out right now. And then I would say my best book, if you want just to check out a standalone book, is called Saint Elspeth. And that's a post-apocalyptic book about a doctor in San Francisco. There's also some aliens that show up. And there's a lot of commentary about fascism in that book as well. I think that's my most finely written book. Really enjoyed writing that one. You can check those out if you'd like. They're on Amazon. And they all have audiobooks as well on Audible. So you can just check me out. Wick Welker, W-C-K, Welker, W-E-L-K-E-R, for my author stuff. Follow me on Blue Sky at Wick Welker. I still have my TikTok and Instagram accounts up, but I do not use them. It's ICU Doctor on TikTok, and then ICU Doctor TikTok on Instagram. Email me if you would like to ask me any questions or anything like that. My email is icudoctorecmo@gmail.com, icudoctorecmo, E-C-M-O @gmail.com. People email me about wanting to have great guests on the show, and I get a lot of offers to have really awesome, qualified guests. I just cannot find the time to sit down and coordinate with somebody. It's really hard. It's really difficult. Don't bother emailing me about trying to endorse any product, because I will not. Anyway, that's it. Thanks for listening. I'll see you next time.